Hey, I'm Carrie Gardner, and I'm a doctorate student in athletic training at Indiana State University. Today, I'm going to be discussing fall risk and lower extremity fractures in the elderly from an injury prevention and disablement model perspective. The levels of prevention that I'll be discussing are the primary, which how we deter or avoid lower extremity fractures, talking about things such as prevention of falls and osteoporosis. The secondary level is early detection of injury and risk. So screening fall risk with single leg stance tests, further investigating with manual muscle testing where we have neuromuscular asymmetries or dysfunction, looking at nutritional screening for the way that our patients are feeding themselves and contributing to bone health, and then bone scans to see what the actual state of their skeleton is at this time. A tertiary aspect is management and prevention. So looking at corrective exercise programming and nutritional counseling and recommendations for bone health. You can see from the diagram that prevention and treatment are very interrelated and overlapping as we're going through to treat our patients for any condition or injury. When we look at the disablement model, we're going to be paying attention to what the overall health condition is and how it affects our patient in these different areas, from their environmental to personal factors, impairments that this causes, and then their activity and participation restrictions. The disablement model starts with looking at our health condition, which for us here today, what we're discussing is the lower extremity fractures in the elderly. So the impairments that they experience are decreased strength, muscle atrophy, and a decline in their physical health and mental health. Environmental factors that come into play is the difficulty that these lower extremity fracture patients have in navigating their environment at home and in public, navigating stairs, the driving and transportation restrictions, and being able to maintain independent living. Personal factors, their ability to, have self-care, showering, and just doing their housekeeping can become affected. Their loss of independence does lead to depression. When we look at their activity limitations and participation restrictions, again, mentioning the driving and loss of independence, this really does significantly reduce their health-related quality of life through the isolation and not being able to attend like church involvement, social functions, the loss of access to like easy grocery acquisition, dependence on others for their needs to be met, and interactions with like their family and grandchildren can be a lot more difficult. Self-imposed restrictions occur in this population too from their fear of falling and from a history of multiple falls. Priorities of these patients should always be kept in mind when we're guiding our decision making and having joint decision making with our patients to help inform them of the preventative corrective exercise adherence and helping them to relate the goals to decreasing the fall risk and adaptation to the exercise programming for the ultimate end result of their quality of life improvement. So when we look at our injury prevention programs, we first really want to break it down to identify the problem. And here we have the risk for fall and the high risk of fracture with falls. 88.9% of lower extremity fractures occur from falls, and that is the number one thing that causes lower extremity fracture in the population of 70 or older. Guiding this our informed decision making would be using single leg stance testing for screening of patients for their fall risk, identifying naturally occurring injury rates or peaks. So the observations and documentation of self-reported falls, making sure we're really interacting and checking with our patients to see, how things are going with them each time you see them. When we identify new and emerging issues and evaluate them, the before and after effects, we can use manual muscle testing to evaluate and identify weaknesses that we need to be addressed and for corrective measures and to improve our physical function, and retest using single leg stance tests. The risk factors for falling in the elderly are either the very most active or least active in this population. Slower walking times, impaired balance, impaired gait. Again, their fear of falling is the number one factor in whether they are going to have to fall. So this stems from frequent falls. They've had serious consequences, impacts on patients psychologically, It leads to self-imposed restrictions in activity and decreased independence. So that history of falling is one of our risks. And then the single leg stance test screening will also help us to identify the risk factors for falling. Risk factors for fracture are low bone mineral density and then poor dietary intake. So low intake of vitamin D and calcium, because vitamin D helps the absorption of the calcium. And then likewise, if our patients are consuming a great deal of caffeine, that has a calcium blocking aspect to it. So the absorption rate isn't what they need it to be at. And then if they have a high consumption of carbonated beverages, that also affects bone mineral density from the phosphates that are in that type of beverage. Looking at the approaches to injury prevention for lower extremity fracture, when we focus on our corrective exercises, really zeroing in on balance exercises, hip activation, specifically on the rotators and the abductors is very helpful. Overall strength and conditioning, quad, hamstrings, glutes, calves, and then cardiovascularly, I'll usually start them out on a stationary bicycle or an aquatics. That is very helpful to get their endurance up, and then you can translate that into shorter walking distances. Environmental accommodations that these patients will need: fall prevention, rubber-backed rugs on slippery floors, handrails for steps and showers, fracture prevention with dietary intake recommendations, again, with the vitamin D and the calcium, resistance training for increasing the bone mineral density, and then our participation activity adjustments, making sure we have those safe environments for them. So all of these things are ways that we can help promote the wellness of our patients. Thank you so much.